So let's go over some of these medication. There seems to be a million medications for these, so let's just kind of do a real quick overview and try to hit some of the high points on these medications. So first we have diuretics, and there's multiple types of diuretics. They all do the same thing in the sense that they're trying to get that extra fluid off of the body. However, fluid is also pressure, so in a way, these are also antihypertensives. Many of them are used to treat hypertension, in that because they decrease that fluid volume, they also decrease that pressure. So the first type of diuretic class is going to be thiazide diuretics, and you're going to notice they all seem to have thiazide in them for the most part, a lot of your most common ones. There's not too much to worry about with thiazides except for two things. The fact that we have you'll see this on every slide, the oh no, the orthostatic hypotension. You worry about the patient, getting that dizziness, lightheadedness when they're changing positions. So we tell them, to change positions slowly when we're teaching them, but also they're potassium wasting. In other words, it's getting rid of fluid, but it's taking potassium with them. So there's this little mnemonic, if you're in the Zide-Mide-Nide zone, then no potassium will be home. So effectively, what do we need to do? We need to teach this patient how to replace their potassium, foods that are higher in potassium, so that they don't have those, dangerous electrolyte imbalances. Then there's going to be loop diuretics, and loop diuretics are going to be one of your strongest diuretics. You can see all of them end in those nide and mide again. So again, if you're in the Zide-Mide-Nide zone, then no potassium will be home. So, this must be another potassium wasting diuretic. So it's going to get rid of fluid, but also going to get rid of potassium. It's a very strong diuretic, one of the strongest that you can use. It's very potent, so even if your kidneys aren't working well, it still can be effective. However, there's 5 things that you should know about loops. One, again, the oh no, the orthostatic hypotension. They're going to be a big fall risk, because what is this medication going to do? It's going to make them have to pee. They're going to get up and have to pee, and they have the orthostatic hypotension, so they're going to be high risk for a fall. Again, the potassium wasting, because it's getting rid of fluid and potassium. And these drugs, since it's so potent, loop diuretics can also be really hard on the kidneys. They can increase your kidney function. And when I say increase, it sounds like a good thing, but increased kidney function or increased creatinine is not good. So in other words, they decrease your kidney function by increasing your creatinine. Also, if given intravenously, loop diuretics have a side effect of causing ototoxicity, or they can be dangerous to the ears. So if you push a loop diuretic too fast, the patient may complain of ringing in their ears. They can have a lot of discomfort, and it could cause permanent hearing loss if done unsafely. So then we also have potassium-sparing diuretics. So with these, we have a lot of there's the ones that end in ride. So if you take a ride, you'll have potassium by your side. So these are the opposite of the potassium wasting. Our only really main worries are about that orthostatic hypotension, as always, telling them to change position slowly, but also they're holding on to potassium. So, where the other patients, like the loop diuretics and the thiazides, we told them, that they need to eat more potassium-rich foods. This patient's the opposite. They're holding on to potassium. So we want them to not intake more foods with potassium, and also be on the lookout for other places where potassium may be hidden. Like, for example, what are a lot of patients that take diuretics? What kind of diet are they on? They're on a low sodium diet, and on a low sodium diet tray, a lot of times you'll find salt substitute, and what salt substitute is made of is potassium. So this patient really needs to be careful and be reading the packages, know how to read labels, and see how much potassium is in their products. They also need to be careful with other medications that can increase your potassium, like ACEs and ARBs, which we'll talk about later. But anything that increases your potassium puts you at risk for having kidney problems. So we want to watch their kidney function really closely. So you'll see that there's a second class here, aldosterone receptor blockers. They're also a potassium-sparing diuretic. It's just a more specific one. And it's here, judging by your tone, your potassium must have grown. Same problems. Orthostatic hypotension, holding on to potassium. They need to avoid potassium-rich foods. Read their labels, make sure they're not accidentally intaking potassium. Watch that kidney function, and watch other drugs that are going to also possibly cause an increase in potassium. So let's get into our alphas. Our alphas don't have that much to talk about, but there's alpha 1 and alpha 2. And alpha 1 are all your ZOS, your ZOS drugs. They all have ZOS in the middle. The biggest concern is just going to be that orthostatic hypotension, that oh no. And these drugs can have a worse hypotensive effect, especially the first time you take them. So you want to tell this patient to take their ZOS dose when their Z's will be close. In other words, especially that first dose, this medication is more effective at night and also decreases the risk of side effects. So usually we like the patients to take their ZOS dose at night when their Z's will be close. So now let's talk about alpha 2 adrenergic agonists. So alpha 2, we're talking about clonidine here. And the little mnemonic is if you take your Dine, you will be fine. If you forget your dose, you will feel gross. And the thing that makes clonidine a little different is it's one of the few drugs that can be given other than PO for high blood pressure. It can be given by patch, and this really helps to increase compliance. The patch is changed every 3 days, so imagine how much easier it is to change a patch every 3 days than it is to have to take a pill every single day, multiple times a day. So this is a great way to increase compliance is through this medication. But some of the side effects, we really don't want patients to stop taking this suddenly. It can have a really bad rebound effect, that rebound hypertension. The orthostatic hypotension, again, of course, the oh no, as always. And then it also has some anticholinergic effects, so it can cause a dry mouth. So we just want to tell them to maybe, be having hard candies and things like that nearby to help with that dry mouth. So now let's talk about beta blockers. So a good thing that beta blockers all have in common is they all end in LOL. So you can remember LOL as lots of lows. They cause low blood pressure and low heart rate. And so another mnemonic you might want to remember is, when beta is at a stop, it can hide your blood sugar drop. But also when beta is blocked, all of your insulin is locked. So effectively what this is telling you is that when you take beta blockers, you need to use caution in patients that are diabetic because normally when patients are diabetic and their blood sugar gets low, how does their body react? If you remember the cold and clammy, give me candy. So this patient gets really diaphoretic. However, they're also not getting enough glucose out. So again, the heart's going to compensate. The sympathetic nervous system is going to be activated. So your heart rate's going to go up. So a lot of times we know a patient is having hypoglycemia because of that cardiac reaction, their tachycardia. But if a patient's diabetic and they're on a beta blocker, their heart's not going to have that reaction. So this patient could slip into a hypoglycemic coma. We wouldn't know it because they're not manifesting it because they're on a beta blocker. So we use caution with beta blockers in patients with diabetes. There's a couple types of beta blockers. There's cardioselective, non-cardioselective, and mixed. So talking about cardioselective, the big thing that we worry about is just the orthostatic hypotension and bradycardia. We want to teach them to change position slowly and also to check their pulse before taking this medication. They shouldn't be taking it if their heart rate is less than 60. So now let's talk about the non-cardioselective beta blockers. So these are going to have all of the same problems that the other beta blockers had, that they cause the orthostatic hypertension, the oh no, they are going to lower your heart rate, so the patient needs to calculate their heart rate and, or should say, measure their heart rate before they take their medication. And also it's going to need to be using caution in diabetics because it masks those symptoms of hypoglycemia. However, the difference in non-cardioselective is that they also cause constriction of the airways because of the receptors they work on. They should not be used in anyone who already has bronchoconstriction. So those are patients with asthma, COPD, restrictive lung disease, smoking, anything like that is going to put them at risk for bronchospasm or closure of their airway. So they're generally contraindicated in people with that restrictive airway disease. Like it says here, if your beta is not cardioselective, your breathing may not be effective. So we just want to be extra careful because obviously this kind of has the benefits of beta blockers, but also the downside that it affects not only the heart but the lungs as well. There's also mixed alpha and beta blockers, and with these, they have a mix of alpha, beta 1, and beta 2. So this means just like the non-selective, they're going to have the orthostatic hypotension, the oh no, the bradycardia, the decreased heart rate, where they need to measure their heart rate before taking this. And then they're going to have the caution for the diabetics and caution for those that have any sort of restrictive airway disease. So these are great in the sense that they can take multiple medications and maybe be more effective. But we need to take a good look at that patient's medical history and the things that they may be at risk for with taking this medication. So that history of diabetes, that history of asthma, COPD, smoking, restrictive airway disease, anything like that, this drug may not be as appropriate for them. There's also vasodilators. So it says here, while dilation is great, you may not be able to stand up straight. So one of the biggest side effects of vasodilators is going to be the hypotension. And I know we've been talking about orthostatic hypotension nonstop. But when I say that these people have hypotension, it is severe hypotension. They also should be avoiding erectile dysfunction drugs because erectile dysfunction drugs are vasodilators. So if you take a vasodilator plus a vasodilator, you have severe vasodilation side effects. So it says nitro and nitrate make it hard to stand up straight. They can make your head ache and turn your face red like a rare steak. And then hydralazine opens up your arterioles to help you meet your blood pressure goals. So hydralazine is going to be the PO option. And also that isosorbide mono and dinitrate. Those are all PO options that can be used to decrease blood pressure. And some of these vasodilators are going to be used in angina, like the chronic stable angina, or heart failure. Then there's IV versions as well. And we really, for Med-Surg, we kind of focus on that, the PO medications. So going along with those vasodilators, let's look at nitroglycerin in a different way. Nitroglycerin can also be given sublingually as an anti-anginal. So as much as it is a vasodilator, it also is going to help to decrease chest pain by using its vasodilation properties. But let's talk specifically about some precautions with nitroglycerin when it's given sublingual. It can be given sublingual, it can also be given via patch, or more of a transdermal paste, I should say. But there's other ways to give it aside from just PO and IV. So we like to give it in ways that are going to be more rapid. So the sublingual is going to be when they're having an acute angina attack, or, that chest pain that comes on suddenly, especially maybe when doing activities and things like that. They can take this medication before they do activities if they know that their heart's going to be more stressed, or they can use it afterward to treat. But the important things to remember about nitroglycerin administration is, we want to protect it from light. It should be in a dark bottle and away from bright sunshine in order to help increase its effectiveness. Again, this is a vasodilator, so we want to be worried about hypotension. They should not be taking erectile dysfunction drugs while taking their nitroglycerin. And then also, when they're taking it, this is going to cause that severe hypotension. So we like to tell people, when you take your nitroglycerin, sit down first. A lot of people take their nitroglycerin when they're, having an acute attack of angina and stuff like that. But as much as they think that they'll be okay, that, it won't affect me that much, it's so important for them to sit down first so they do not fall or have a worsening injury. So there's also ACE inhibitors. ACE inhibitors, so some of the common ones, you can see that what they all have in common is they end in pril. So, the little mnemonic I have is a pril can make your blood pressure chill, but also can make your kidneys feel ill, and you better not take a potassium pill. So this really tells us a lot of what we need to know about this medication, in the sense that, again, the orthostatic hypotension, oh no, that it can cause potassium problems, and as well as angioedema. So when it's saying potassium problems, what am I saying here? Well, earlier it talked about not wanting to take a potassium pill. And what I meant by that is that you can have accumulation of potassium with ACE inhibitors, or you can hold on to potassium. So ACE inhibitors block the renin-angiotensin-aldosterone system. And aldosterone, one of the ways that it works is it holds on to sodium and lets go of potassium. However, in this, we're blocking that. So then we're going to start to let go of sodium and hold on to potassium. So you can have an increased potassium, which can be really dangerous for people, especially, remember we talked about with potassium-sparing diuretics, can be dangerous for that patient that has kidney problems. So there's also a rare but possible side effect of angioedema, and that's what is important. It's always, remember I say it's important to know, not just common side effects, but also those deadly ones. So angioedema is, that kind of swelling, like an anaphylactic reaction. It's a hypersensitivity, swelling of the mouth, the lips, the tongue. You can swell anywhere with angioedema. A lot of times it's with the face. There's also the most common side effect of ACE inhibitors, the thing that people complain the most about is going to be that cough. So it's this dry cough, and it kind of can sometimes keep them up at night, really annoying. It's not life or death. It's not a sign that they have an infection. It's not a sign that something's wrong. It's just a side effect of this medication. It's very common. However, a lot of people don't tolerate this, and we've talked before about having problem with compliance with meds. So if patients can't tolerate that cough that they get with ACE inhibitors, they have another option. And that option is going to be ARBs, or ARBs, angiotensin receptor blockers. And so these take a little bit longer to start working. They all end in sartan. And you can remember taking a sartan will stop your cough from starting. But they can have potassium problems as well. Same thing, potassium problems and angioedema can still happen in angiotensin receptor blockers because they're still blocking that aldosterone and causing those problems. However, the big difference, or really the only difference between angiotensin receptor blockers and ACE inhibitors is going to be in that there's no cough with this one. They do take a little bit longer, like I said, to start, but the big difference is if you're not tolerating an ACE, an ARB is a good option for you. Same side effects, same issues on that side, except for that cough. So this can be a great option for someone who's just really not handling that cough well. There's also calcium channel blockers. So calcium channel blockers, there's two classes. There's one class that's going to help with dysrhythmias, and you can see this is Dill and Pam will make your dysrhythmia scram. So we worry about with calcium channel blockers, of course, bradycardia, because if it's helping with dysrhythmias, it's going to help slow things down. But they can also have orthostatic hypotension, so that oh no, again, of course. Then there's also the other class of calcium channel blockers that help with hypertension. That's going to be your dipines. So dipines are dihydropyridines. They open your vessels wide so your blood can move around inside. Isn't that nice? So with the other class of calcium channel blockers, your main worry is going to be orthostatic hypotension. But they can also possibly decrease your heart rate. So for both these patients, you want to make sure that they check their heart rate before, that it's greater than 60, and that they're changing positions slowly. So let's get into some anti-lipidemic drugs, or some cholesterol-lowering drugs. So first there's statins, and statins are going to be your most common drug. So statins, the most common side effects, are going to be people complaining of, muscle issues like muscle pains, tummy ache. Their liver enzymes can be elevated and they can get a rash. So we really need to watch this patient's liver. We're really worried about their liver function because all cholesterol is made in the liver. So anytime you mess with where something is made, you can decrease the function, you can cause inflammation, irritation to that area. So we want to keep a close eye on their liver. But then we should also know that muscle pain is not a good sign. So even though I said that muscle pain was a common symptom, when they start to have muscle pain, it's something they should report to their doctor because it can be a sign that they're going into a complication of rhabdomyolysis. And what's rhabdomyolysis? It's a breakdown of the muscle, and that clogs the kidneys and you can end up in multiple organ failure. But effectively, if a patient who's on a statin is having muscle pain, pain, they should report it to their physician so that they can make sure that they are not going into that rare but potentially fatal side effect of rhabdomyolysis. There's also niacin, which is a vasodilator, so it causes flushing. You might see, red, rosy cheeks. Again, these are hard on the liver, and they can cause these are vasodilators, so they can cause that orthostatic hypotension, the oh no. So what people do to prevent that flushing, that uncomfortable effect of the flushing, is they'll take an NSAID about 30 minutes before to prevent that local vasodilation, so that they can be more comfortable. So there's also fibric acid derivatives. Both of these you can see have Fib in the middle, so that's one way to remember this medication. They also can cause liver problems, and you should not take them with a statin. They will actually cause you to have worsening of that muscle pain and a higher chance of having muscle pain in general. They worsen all of the side effects of statins. They kind of work synergistically, but not in a positive way, in the sense that they're both working in similar areas and can cause those liver problems to get worse, and therefore also some of those muscle problems if taken with a statin. They also interact with a lot of medications, so be careful and make sure that your pharmacist is checking through and looking at all the medications your patient's taking, as long with their fibric acid derivative. So some other cholesterol medications are omega-3 fatty acids, which work mostly on decreasing your triglycerides. So omega-3 will make your triglycerides free, but the patient may have joint pain as a result of taking these. There's also bile acid sequestrants. They all have chole or coal in them. So good old King Cole went to the liver and stole all the cholesterol, which was the end goal. But of course, these are working in the GI system, so they can affect medication absorption. So we want to be super careful with medications that we're giving at the same time. Believe it or not, there's even more cholesterol medications. So there's also PCSK9 inhibitors. They're the QMABs, which make your LDL easier to grab. And that's a sub-Q injection. So this is not going to be your first line treatment, but if all else is failing, this is an option. And there's also cholesterol absorption inhibitors, which are the MIBs. They're part of the inhibitor tribe, but they also can cause liver problems. So we'll just watch the liver function closely. We can't forget about our other cardiac medications such as aspirin. Aspirin is usually 81 milligrams for cardiac prophylaxis. It's an antiplatelet. It is not a blood thinner. There's actually no such thing as a blood thinner, but aspirin and clopidogrel on this page are both antiplatelets, which means they stop the platelets from sticking together so much that you won't be as likely to form clots. Aspirin is very well known for having a lot of interactions. A lot of people have allergies to NSAIDs and therefore have allergies to aspirin, but they also really irritate the stomach and can lead to GI bleeding and other problems. So usually you want to take this with a full glass of water or with food because it can irritate your stomach. We do also worry about the tinnitus or the ringing in the ears as a side effect, and that it can be hard on your kidneys. So if you don't tolerate the aspirin well, then you can also try clopidogrel, which is also known as Plavix. It has less side effects, but with both of these, the big thing that we want to teach is bleeding precautions. These patients are going to be high risk for bleeding because even though it's not a blood thinner, it's stopping them from forming so many clots, and this can affect their ability to stop bleeding once they start. So let's talk about what most people know as blood thinners, but like I said, there's no actual true thing as a blood thinner as much as there's anticoagulants. So these aren't thinning your blood. What they're doing is they're stopping a part of the coagulation cascade, stopping you from forming clots. So these do not break down clots you already have, but they stop you from forming new clots. So the most common one you probably have heard of is warfarin, and this is also known as Coumadin. It's a PO medication. It takes some time to get in the system, so a lot of times we have to put a patient on another medication, kind of bridge them over to this PO medication, and we do that. We watch that, how effective it is by looking at this patient's INR, and that's going to kind of tell us where their blood levels are, how anticoagulated their blood is. And so for a patient that's on warfarin, we like their INR to be between 2 and 3. We want to teach this patient bleeding precautions. The antidote for warfarin is going to be vitamin K, and we want to make sure in their diet that they know to maintain the same level of whatever they've been eating in vitamin K, green leafy vegetables, and things like that, that they're already doing. So it's a common misconception that you have to cut out all vitamin K. If your body's used to eating vitamin K, that's what you should keep up with. However, you shouldn't make any drastic changes to your diet in this time, and try to keep a steady state where you're not going to change the absorption of warfarin by taking in too much vitamin K. Because remember, vitamin K is the antidote to warfarin. So if you have too much of it, you're literally going to make the warfarin not effective. There's also unfractionated heparin, or just heparin as most people know. And you can remember heparin will make your blood thin. This is given sub-Q and IV. It's not a PO med. This is one of the medications we can use sometimes to bridge a patient onto warfarin. Instead of an INR for this patient, we watch the APTT, and we like that when it's therapeutic, we like it to be about 46 to 70. If we have too much heparin on board, we can give the antidote of protamine sulfate. And again, we're going to teach bleeding precautions. No straight razors. We like to use electric razors, soft bristle toothbrush. Avoid excessive IV sticks. Protect the skin, avoiding trauma. Ask for help when you're getting out of bed. The list goes on and on. Just be really careful with this patient. Heparin, however, also has other side effects. Long-term, heparin can cause osteoporosis, and there's a syndrome known as heparin-induced thrombocytopenia, where you have low platelets and you start clotting. As weird as it sounds, yes, you start clotting even though you're on an anticoagulant, but this can lead to a lot of issues. So we're going to watch the platelet count on a patient who's on heparin as well, to be monitoring for that heparin-induced thrombocytopenia. So the next drug we have is low molecular weight heparin, so also known as enoxaparin or Lovenox. There's no monitoring for this drug. We may keep an eye on the platelets, because even though it's a less chance of them having the heparin-induced thrombocytopenia, this still is heparin, so they still have a chance where they could have that HIT syndrome. The antidote is still protamine sulfate. So as a whole, the benefits of low molecular weight heparin are going to be less complications. So they have a lot less chance of getting that hit of that osteoporosis. There's minimal monitoring needing, just watching the platelets. And it lasts longer. It has the longer half-life, and it really stops that clotting process. There's also some new age oral agents that can be used for anticoagulation. One of them is going to be dabigatran. It's PO. There's no monitoring. We're going to give them the same bleeding precautions that we've given everyone else. And you can remember, you don't have to dab. You don't have to do any blood work. There's also rivaroxaban and apixaban. And these both blocks XA, and the nice thing is that the drug companies actually put XA in everything, including the antidote. So if you ever see a medication with the XA in it, I shouldn't say any, but I'm talking about the ones that you might see on an exam, if it has XA in the middle, it is a factor XA inhibitor. So they block XA. These are all PO. Again, no monitoring needed. We're just going to maybe keep an eye on their blood counts and things like that routinely. So now let's talk about positive inotropes, and the main one we talk about, even though it's not that commonly used in practice, is going to be digoxin. Digoxin has 3 properties. It helps increase your contractility, or your heart squeeze, which could be helpful in heart failure. But it also can help with dysrhythmias by decreasing your heart rate and decreasing your electrical activity, or that electrical irritability. So like if you're in a rhythm like AFib, it's going to help to decrease some of that electrical irritability. However, it has a very narrow therapeutic index, so we like to keep the level between 0.5 and 2. We'll know that it's reaching toxicity if the patient starts to experience really bad GI upset and GI symptoms. Also, if they start to see halos. Those are the early signs of digoxin toxicity. The later signs are actually going to be like a severe, profound bradycardia. If you've had too much of something that's going to lower your heart rate, it's going to severely lower your heart rate when you're at that later stages of it being toxic. We also want to watch their heart rates. They should learn again to check their pulse, and their pulse should be above 60 before taking this medication. And then, of course, always worry about the orthostatic hypotension and that oh no, wanting to tell them to change positions slowly. So last but not least, there's also antidysrhythmic meds. We don't go in depth with these, but here's just a couple mnemonics. Amio will make it slow. Atropine triples the rate of the pulse. Adenosine discontinues the electrical node. And PAM is, I like the one, the pulse accelerating machine. So as a whole, if you need to speed up the heart, atropine and pacing is where to start. If you need to slow it down, beta blocker should come around. If you're trying to get back to sinus, send an amiocardia and dig to show off their highness. So just a couple little mnemonics there. I hope this was helpful and just kind of help sum things up. There's so much I could talk about for a long time on these medications, but try to just pick up the pieces. Remember what's common that I should expect. How will I know this medication's working? And then also, what's there a sign that maybe something's not going right and maybe I need to hold the medication, or maybe I need to do a follow-up assessment or do something, to prevent the patient from having some sort of harm done to them. These are a lot of medications, but they're also a lot of fun because they're cardiac, so try to take them in the best that you can. Thanks for listening.